Good afternoon, and welcome to the first seminar of the year in the series of the Department of Epidemiology on Wednesdays. It's a bit of a tradition, David, that you give the first seminar, and it's wonderful to have you then. David is remarkable. He is at three institutions, different institutions at Harvard. Faculty of Arts and Sciences, History of Science, in, social medicine and global health in Harvard Medical School, and of course in our Department of Epidemiology here in Harvard Chan. And you will speak about today a very topic dear to our hearts, excess death, history of a contested concept. Please go ahead.
I'd like to thank Bert for the continuing invitation to kick off the seminar series this fall. And I'd also like to thank several people who are affiliated with the school who were helpful as I was preparing these comments, Mary Kay Smith-Ozzie, Carolyn Buckey, and Satya Balsari, for sharing their experiences with this concept in some of the debates. You'll see their work shows up at the end. And also now realizing that Mark is here in this room, I'm now warier because there are people here who have enormous expertise on some of this material. I'll be very interested in hearing what you all think of this. So in writing a forum in the American Journal of Public Health in 2024 dedicated to the concept of excess deaths, Brigham and Women's Hospital's Jeremy Faust described an interesting irony. As he wrote, all-cause excess mortality rates exceeding expected values, agnostic to cause, provides perhaps the best and least biased measure of the most severe effects of an acute outbreak. But then he provided the caveat. In the fullness of time, there is no such thing as an excess death, as all people die precisely once. Now, I have long been puzzled by this issue, which isn't just a semantic one. Excess deaths are clearly a useful concept, and they come up all over the work I've done on the history of epidemiology, on air pollution, on heat-related mortality, and elsewhere. It's useful because the concept can make visible deaths being caused in ways that would not otherwise have been obvious. Heat, I'll come back to, is an important case there. But what does it mean to say that a death is an excess death? As Faust says, everyone dies once. At some level, it's a normative judgment. Some level of deaths are okay, but deaths above that are excessive. And there's also a claim about attribution. Whenever you see a spike in mortality from an unclear cause, you then have to make the assertion that these excess deaths are caused by this cause that I'm interested in. And neither of those claims is straightforward, and both of them have opened the door for critiques of various sorts. And so if you just do a quick search in any different format on the literature of excess deaths, you'll see a number of places where these have become controversial, both as a matter of epidemiological and biostatistical theory and practice. So the exact details of how you calculate excess deaths has become quite sophisticated, and also as a matter of politics. Saying that deaths are excessive implies that someone or something is responsible, and something should be done to get rid of this problem. And so I was curious to learn more about this concept. I decided to take a quick look to the history. Couldn't find anything really good that has been written really describing well how this history developed. And so I did the simplest thing to do, which is to start off with a Google Ngram search. Easy to do, and it suggests on first pass that there's a very interesting story here with three different spikes in the use of excess deaths over the 20th century. Still haven't figured out exactly what's behind that middle one. The first and the third of those are obvious. But like you do with any simple-minded method, you quickly run into trouble. There are a whole series of related phrases that also circulate. Should you talk about excess deaths or expected deaths? And if you look at those two, you see they have very distinct and suggestively different trajectories. There's another concept, premature deaths, which likely means something slightly different, but it overlaps. And it turns out that phrase circulates even more widely, especially now. And then as you look at the literature, you will realize that some people talk about excess deaths and some people will talk about excess mortality, I think meaning the same thing. But then if you look at the graphs of the phrases, again, they have a different time trajectory. And you can do the same thing with expected mortality, excess deaths. There's another phrase that circulates, again, with slightly different meanings, but overlapping usage on unnecessary deaths. You don't want to get carried away here. The actual volume of material that's in the Google Books corpus is corrupt in various ways. A lot of the metadata is not correct. If you look at time series, you realize that the publication date that they have listed for a source actually isn't the right source. And so you can't really do this in a sophisticated quantitative way. But the basic message, I think, is clear enough for my purposes. The idea has been around for a while. It's being much more widely used now than in the past. And it suggests that there's actually an interesting history there. So I set out to try to pin down a bigger picture overview of the history of the concept and its related concepts. When, where, and why did they appear? And then how have the specific methods and the controversies about those methods developed over the course of the 20th century? I focused on searching the key journals for the field, at least from the US perspective: Public Health Reports, American Journal of Public Health, American Journal of Epidemiology, and MMWR, and then its various predecessor publications. And then also tracing citations backwards within articles to see what were the key concepts, which articles were seen to be the most influential on the development of this. There are a whole lot of loose ends. I'd love to hear any thoughts and suggestions you have about all of this. I also have a lot of excess material about this. I will try not to race hard, but I'm really just trying to give you a sense of the overview. Everything I'm talking about, I could talk about in much more detail than I have time to present here. Yeah?
Early on, you used the term satellite excess deaths, but it's different. You used the term excessive deaths. Excessive deaths sounds to me like a positivist kind of thing. Excessive sounds very judgmental. Is the literature using excess deaths or excessive deaths?
Both. And seemingly interchangeably with no rhyme or reason. And someone will switch usage in the middle of a single article. Now, there may be people who mean different things by that. But if they do, it's not clarified or used consistently. So the usage is a morass, which is why you can only get so far with any of these quantitative tools.
This question reminds me, this is being recorded, so if you don't want to be recorded, you should not ask questions. To say this.
So most people now, if you look at the reviews that have been written within the field, most people credit William Farr with the key insights behind excess deaths. Farr is widely considered one of the founding figures of modern epidemiology. He was charged with keeping track of vital statistics in England in the mid-19th century. Over his long career and seemingly countless publications, he was interested in many, many questions. And one of the questions he wondered about was what would be the natural rate of mortality in a human population living in healthy conditions. He didn't think any population in England was living ideally, but he was curious to see what he could learn from England itself. And so he looked at the mortality rate in all of the different districts in England in the 1840s. The average was a mortality rate of 22 per thousand, but there was a wide range from 15 per thousand in the healthiest districts up to 39 per thousand in Liverpool. And he concludes from that 17 per thousand is a reasonable baseline. He admitted that there are things people in England that could do to live a healthier life, but he thought 17 per thousand was pretty good. And then anything above that, he considered to be an unnatural death, was the phrase that he used, attributable to artificial causes, which were potentially addressable. For instance, he calculated that in England in 1857 had 91,652 excess deaths. He says for the 419,000 persons died that year, only 328,000 would have died had mortality not exceeded the threshold of 17 per thousand, which of course was an artificial threshold. And he admits that England might be a wonderful place. This was when England was at the height of its imperial power, but it still had an enormous amount of unnatural death and suffering that the country needed to be held accountable for. So he defines the basic idea, uses some of the language, and uses it in various ways throughout his career. And the phrase itself circulates pretty widely. You can find it all over Google Books in the late 19th century, in discussions of plague outbreaks in India, or when there are famines in India, the British writers will talk about the excess deaths caused by the famine. My favorite find is this one, a report from 1910 about the occupational mortality in the pottery trade, specifically caused by lead. The most interesting thing is the author is Winston Churchill, who early in his career, before he was prime minister, turns out wrote a report on occupational health. He thought lead was a red herring. It was really respiratory disorders and tuberculosis, which was the true bane of existence of potters, which makes perfect sense in retrospect. But the thing that's interesting about how he uses the phrase is it's completely uncomplicated. He just assumes that everyone knows what it is. It's not hard to calculate. You just count deaths, determine which ones are excess, and there you have it. And you'll see that in the scattered usages that come up in the late 19th, early 20th century. The concept really comes into its own with influenza in 1918. After the initial cases in spring 1918, the main epidemics hit in spring 1919. The US Census, which was involved in this business at the time, and also the Public Health Service obsessively track influenza all the way through the winter of 1918-1919. And you'll start to see reports like this. This was the Weekly Health Index, the predecessor of the MMWR. But at the time it was produced by the US Census under the Department of Commerce, not from the Public Health Service. And what they do is, you can see they report excess deaths from all causes and also excess deaths from influenza. And the footnote gives the useful intuitive explanation. Excess deaths means the number of deaths from all causes in excess of the number which would have occurred had the 1917 death rates for the corresponding months prevailed. And so initially, as it's used here, it's a temporal comparison. Mortality this year compared to the mortality last year, assuming that last year's mortality is a useful baseline. And again, this was relatively early. They're talking about it on a monthly basis. And so you compare September 1918 to September 1917 and declare excess deaths. The concept gets used widely during the pandemic, developed by many of the key figures in the field at the time. You have people like Edgar Sidenstricker, the Public Health Service, or Wade Frost, getting the names backwards. Wade Hampton Frost, thank you, at Hopkins and Department of Epidemiology. There was a lot of collaboration back and forth between Hopkins and Public Health Service at that time. So Sidenstricker and Frost offer international comparisons, trying to figure out on a country-by-country basis what % of each country's excess deaths could be attributed to influenza. In August, Raymond Pearl, another huge figure in the field at the time, talks about how the mortality from flu had been appalling. We'll never know the true toll, but what he was interested in is looking at the 25-week excess death rate as a measure of the force of the epidemic. So if you compared excess death rates between different places, you could make a comparison of who had been hit hardest by this. One of the observations he makes is that cities that had been least healthy before the pandemic, so the sickest cities before the pandemic suffered the most during the pandemic, which is an interesting observation. He doesn't offer much of an analysis of that. He just notes people who had been badly off beforehand did badly during the pandemic. Now, a lot of these uses early in flu were purely descriptive work. There wasn't a lot of mathematical sophistication behind that. But that changes over the next several decades. And so even though the 1918 pandemic has been described by historians as the forgotten pandemic, and it didn't get a whole lot of attention in this country until COVID brought it back to relevance, the 1918 pandemic was never forgotten by the Public Health Service. The people who worked there were completely obsessed with influenza all the way through the 20s, 30s, 40s, into World War II. And one of the key figures there is this person I had never come across before, Selwyn Collins, who works at the Office of Statistical Investigations of the Public Health Service for 40 years, from 1920 to 1959, works with Sidenstricker, works with Frost, works for many others. And he publishes dozens and dozens of reports over his career about excess deaths from flu. And so, for instance, they were paying very close attention. You can find reports published in the 1930s about the 6 flu pandemics in the US in the 1920s. And most people don't even think of flu being a problem in the US in the 1920s. If you were there living at the time, you were very concerned about this. And so they would compare the 1927 epidemic to the 1929 epidemic. And excess deaths were important for all of it. As they do this, they start to realize that the question of what is the baseline is an interesting problem. As they saw flu pandemics year after year after year, that distorts the baseline. So if you're looking at 1919 mortality, you can't use 1918 as your baseline because 1918 had the flu pandemic. So they would hold the baseline constant at 1917 levels. So in the early 20s, they're comparing everything that happened back to 1917. But by the late 1920s, they realized that's not a very good approximation. So they find 3 years during the 1920s that they considered relatively flu-free, and use those as the baselines for comparisons to the late 1920s. And you start to realize the kind of elaborations they have to do to make the concept work. And then you can also see, if you look through, they're trying to figure out ways to make this more visually attractive. So this is an example of one of their early charts. An enormous amount of information here. The signal does not jump off the screen if you look at that plot. You really have to look carefully at the pluses and minuses and see where the numbers are to see where the epidemics are. They realize graphs are much more useful, and so this becomes the kind of standard figure that you will see doing this. They hold the baseline flat. I'll say more about that in a second. And then you can see the various spikes that are usually occurring in the winter that were usually attributed to flu. As they go through and they get better and better data, they start to have weekly data, not just monthly data. And they start to accumulate data from a larger and larger sample of the US. Initially, they just have data from about 40 cities or so. Eventually, they end up with data from about 98 cities across the country. They divide the country into regions. And then you can do comparisons looking at the excess death rates to see when and where a particular epidemic started and how it was moving over time, and then try to understand what was going on with the regional variations. They also noticed some interesting correlations. One thing they saw that every time there was a spike in flu mortality, there was also a spike in all-cause mortality other than flu. And so I became curious about what was going on. As they wrote, for every period in which there was a definite peak of excess mortality from influenza, there was a corresponding peak of excess mortality credited to other causes. And so they're trying to figure out why is it that flu is triggering mortality in heart disease, all other causes except cancer. Cancer mortality was independent of flu, but basically every other leading cause of mortality would spike when flu spiked. And they say, one possible explanation would be that persons with certain chronic diseases are easy victims of influenza and pneumonia and die during the epidemic, but then that might get reported as a different cause of death than influenza itself. And so they wondered, and again, the attention comes to focus on heart disease, which is where most of the excess deaths during flu not caused by flu were caused, heart disease, trying to figure out, was there something about influenza that was triggering people to die from heart disease? And as they continue to do this work in the 20s and 30s, you start to see more and more complex accounts of the mathematics behind this, and especially this question of how you calculate a reasonable baseline. And this was sort of the bedrock of a lot of their work. Wade Hampton Frost, writing in the American Journal of Epidemiology in 1935, praises the method. He says that excess deaths can be used to track epidemics across time and space. You can, as you get better data, you can use them to make comparisons by race, by sex, by age. And he says, well, the method has obvious limitations. It has the merit of being entirely objective, which was an interesting claim to make because they knew it wasn't objective. It depended on what you defined as your baseline, which they, by 1935, they had been puzzling about for 17 years. But again, there was this, they really saw it as the most useful marker of the basic facts of a pandemic. Collins keeps his work up trying to refine the methods deep into the 1950s. In 1957, he publishes a monograph, which really is a summary of his life's work at the Public Health Service. It gets published by Public Health Reports. And it's full of interesting data. He has the composite graph on the right, which shows the 40-year trends of various different causes of mortality, heart disease, influenza, cancer. You can see most of them are going down. Childbirth, chronic nephritis, tuberculosis. Cancer is going up steadily over the 20th century. Heart disease is also going up. But one of the things that's interesting is you can see the annual variation in mortality rates for all forms of disease, more or less except cancer. Cancer has much less month-to-month variation than the other causes of mortality. Their assumption was that there was something about seasonal influenza that was driving all forms of mortality other than cancer. The focus of this work, which had been building steadily for 40 years by the 1950s, really shifts after 1957. And so 1957 was the first major flu pandemic since 1918. So if you were going to talk to people now, which epidemics of flu have you heard of? Many people would say 1918. People who know the next round of material would say, well, 1918, 1957, 1968, 1976. Those are the usual four that people talk about. When 1957 hits, that gets people's attention. And so by this point, Alex Langmuir had set up the Epidemiology Intelligence Service at the CDC, the goal of which was initially surveillance against bioterrorism. So surveillance was part and parcel to what the EIS and the CDC were up to. And so in response to the 1957 pandemic, he creates a flu surveillance unit within the CDC, the purpose of which was to keep a very close eye on flu data in real time to see what's going on. And the desire here, like all the work that Collins and the others had done, had been retrospective. How could you look back from the present at past epidemics to understand the epidemics? Langmuir wanted something different. He wanted to focus on the here and now. So his goal was to develop a tool where you could predict what the expected mortality was for next week or 2 weeks from now or 3 weeks from now, and then you could immediately detect if there was a deviation in that, presumably caused by flu. And so he says they develop a new linear regression formula that allows you to predict mortality week by week. So he says for each week of the epidemic, the estimated expected incidence was obtained by the least squares estimate from a straight line fixed to the corresponding week in the preceding 3 years. So they're taking the previous 3 years of data, extrapolating forward what the predicted mortality would be, and then you could see right away when the weekly returns came in, did you have a deviation in flu cases? And they also developed new ways of graphing which start to show the seasonal variation in flu mortality, not the flat baseline that you saw in the first generation of graphs. And then they continue to elaborate these methods. This is an article in JAMA in 1961 by the CDC. They said that the 1957 strain had 86,000 excess deaths compared to roughly 500,000 for the US for 1918. And then what they do is they define an epidemic threshold. So what counts as a flu epidemic? They set it at 1.65 standard deviations above the baseline for 2 weeks. And I assume someone here might know, like, what's the meaning of 1.65? Sometimes it's 1.64, but somewhere in that range must have been some threshold of significance away from the baseline. But then so what they would do is they would track the data. If they were more than 1.65 standard deviations up for 2 weeks in a row, they would raise the flag and say we are in a flu pandemic. You also start to see in the 1950s interest in the question that is now often referred to as this concept of harvesting. If there's an epidemic, it kills a lot of people, but what percentage of those deaths were people who were about to die from some other cause pretty soon anyway? And so what they will say is if you look at the data after each pandemic, there was a small but consistent deficit of observed deaths in the aftermath, which reflected the widespread assumption that flu was killing a lot of people who were already sick and would have died within a few months even if flu hadn't gotten them first. But they're quick to point out that the size of the deficit was small. They say this suggests that most victims of an influenza epidemic are those who would have lived considerably longer had influenza not claimed them. And so even though they do see this harvesting signal, they're quite clear to say that this is a small effect and it shouldn't be used to minimize the impact of these flu pandemics. By this point, one of the people who has taken over as the head of statistics at the CDC is Robert Surfline. He picks up where Collins had left off and continues to refine these methods. His goal was to create region and season-specific curves of expected mortality to allow rapid detection, localization, and severity estimates of each new epidemic. And the underlying math to do so becomes much, much more elaborate and quickly goes beyond what I can understand as a historian and psychiatrist. The MMWR is paying very close attention to flu and all of this in the 1950s, 1960s. They start producing what they call the current mortality chart. This is from 1968. You can see that their graph of the actual mortality and then their prediction of what mortality is to come. Again, to make it easier to do the surveillance to show, help you realize when you are in an epidemic. You also start to see more explicit policy-related uses. So in 1960, the US launches its first serious effort at national flu immunization to prevent the seasonal pandemics. 4 years later, in 1964, Langmuir and Surfline publish an analysis. Has this investment in flu vaccine made any difference? And their conclusion was not really. If you look at the number of expected deaths, they did not decrease in the subsequent years. They said the vaccination campaign hadn't helped likely because they weren't very good at predicting what the future circulating flu strains would be, which again is part of one of the challenges we face now. And so again, so in this period from the 1920s to the 1960s, it's really in the domain of flu that this technique is being developed and becomes much more sophisticated over that 40-year time frame. But as they're doing this work, they start to realize that it's useful for other topics as well. The one that comes up first and most regularly, and I don't think it's just because I was looking for this, is heat-related mortality. And so what happens is when you make these graphs of excess mortality, you start to notice that every so often there'll be a spike that's not during flu season. So here's 1925, here's the peak from flu, mortality is coming down, and then there's a very sharp peak in June 1925. And so the question was, what was causing these non-seasonal flu-related mortality peaks? And in this case, they said, oh, this was a really hot week in New York City. Maybe this is heat-related mortality. In 1934, Collins teams up with Mary Gover, who was a statistician in the Public Health Service. They look at a spike of summer deaths in 1934, realize you only see it in certain regions of the Midwest, and that was in a region of the Midwest that was suffering from a drought and a heat wave in 1934, part of the broader Dust Bowl that was so disruptive for U.S. agriculture in the 1930s. Gover then proceeds to write the first extensive review of heat-related mortality in the U.S., published in 1938. She said, one of the problems with heat was that it's almost never written down as the cause of death on death certificates. And so she said that excess deaths really is incredibly valuable here for bringing to light these deaths that were otherwise not being noticed. And then she makes a few analytic conclusions. She has a lot of data by 1938. One of the things she realizes is it's not the absolute temperature that's so dangerous. It's the deviation from the region's usual temperature, which makes sense. And then she was also the first to realize that the first heat wave of a season is much more lethal than subsequent heat waves, which is seen as evidence of acclimatization. So if you have a huge heat wave in August, but you'd already had one in June, it's the June heat wave that kills people. And again, you'll start to see you'll see these discussions about harvesting. So when there are reports of heat waves in New York City in the 1950s and 1960s, consistent debate about whether heat is just killing people who are about to die anyway. And again, the underlying question here is how concerned should we be about this, or is this just something that is slightly prematurely ending people's lives? Another area that comes up in the 1950s, 1960s is air pollution-related mortality. Not always using the language of excess deaths, but clearly using the concept. And so this was an early report on the Great London Fog in December 1952. They talk about at the week ending December 6th, deaths were normal for that time of year, but there was a huge spike. The following week, deaths rose to a figure far above the normal winter maximum. Those were the excess deaths that were attributed to the air pollution. London and other cases had made the impact of severe air pollution episodes quite clear. Epidemiologists quickly become interested in the question of whether chronic exposure to lower levels of air pollution is a significant problem. That becomes a major area of research at this school decades later, but here they're worried about it in the 1950s. There was an analysis in New York City in 1953 where they compared mortality to the recent years. They realized they're dealing with small numbers of deaths. You have to be really careful of confounders. For instance, if there happened to be a train wreck that killed 40 people, that would actually show up as a spike in the excess deaths. So before you attributed something to air pollution, you needed to make sure there hadn't been some other civil disaster that previous week. But they go through this and they convince themselves that even modest levels of bad air can cause significant numbers of excess deaths. But again, you can see them struggling to develop these methods. This was a report of a New York City air pollution episode in 1962. The official conclusion was there was no relationship here. There was an air pollution spike on November 30th. There was a mortality spike on December 1st, the next day. And they say that shows that there's no effect of air pollution. We have no idea what was causing that spike on December 1st. The explanation that would be given now is that air pollution often has a one-day mortality lag. So there'd be no surprise for any air pollution researcher now to explain this. But they really were not thinking in terms of these mortality lag arguments, at least in this first generation of work on air pollution and excess deaths. Tobacco, not surprisingly, becomes a major area of research on excess deaths. This was a report from 1959, before the Surgeon General's report, arguing that cigarette mortality was 30% higher in smokers than in non-smokers, proportional to the number of deaths smoked each day. 30 years later, Bill Foege, this was, I think, after he had done his work on smallpox eradication, describes the continuing mortality, the fact that there were still excess deaths from smoking, as a public health disgrace. Like, we had identified the problem and hadn't yet figured out what to do about it. And then one of the last example I'll give of this is a subplot that runs all through of this, which is the issue of race disparities. Race has been an enduring fascination of physicians and epidemiologists in the US. In the 1920s, there were a series of studies of the health of immigrants, especially Chinese Americans. This was right around the time when the Chinese Exclusion Act was passed. And there were reports that were saying there were excess deaths amongst Chinese Americans wherever you look, whether it was in Hawaii or California. And the conclusion here was that this was because of inherent racial characteristics. So the fact that Chinese people had excess deaths wherever they went meant that there was something wrong with Chinese people. Again, not the kind of conclusion that you would make now, but this was very much the language of the day in the 1920s in the setting of very racialized immigration politics. If you fast forward to the 1980s, excess deaths play a major role in what, in retrospect, was an important report, the Secretary's Task Force on Black and Minority Health in 1986, which was really the first time the federal government did a deep dive into the problem of race disparities in this country. They do a lot of work with excess deaths, but define it in a different way. Instead of defining it chronologically, like comparing 1918 to 1917, they compare across deaths. So they will say an excess death was defined as the difference between the number of deaths observed in the minority populations and the number that would have been expected if the minority population had the same age and sex-specific death rates of the non-minority population. So essentially what they were doing was saying the white mortality rate is the baseline, and then we'll look at deviations from that. And if you do that, you see that there are excess deaths amongst both Black Americans and Hispanic Americans. This raises a lot of questions. David Williams, who was still at University of Michigan at the time, wrote a lot about this. And again, the question is, what's the baseline should you use? If you use the 1986 baseline of white as baseline, then you realize that Asian Americans have negative excess deaths. They were dying at lower than the white rate. So maybe he says, well, maybe we should define Asian Americans as the baseline and then look at all the other groups' excess deaths above that. And there's really no good basis for saying which baseline is the right baseline. Any baseline claim you make is going to be a politicized claim. You have to plant a flag reflecting a whole series of value judgments about what the baseline is, and then make the comparisons against those. And then also David Williams, you won't be surprised to hear, rejects the conclusion in the 1920s that these disparities reflected inherent racial characteristics. And he starts really pounding on the claim that this is really about social and environmental determinants of disparities and nothing to do with genetics. And so for the most part, if you trace this literature up through the 1980s, you don't see, or I have not yet found any controversies related to excess deaths. It's being used widely. Sometimes it's being used with a lot of mathematical sophistication. Sometimes it's being used in a much more intuitive ways. They were aware of issues of the baseline and different ways to define the baseline. But no one was really losing a lot of sleep over this. And I haven't seen any public controversies about the concept. If anyone knows examples, I would love to see them, because it changes pretty quickly in the 1990s. And a variety of things happen. One is that excess deaths start to be used to quantify various kinds of humanitarian emergencies. And there are various research groups that push this, saying that excess mortality can be used to reveal both the existence of a crisis and also to monitor the humanitarian response. Usually this is done in a simple way. They will say that mortality attributable to the crisis is above and beyond what would have occurred in normal conditions. Again, you have to define what is the normal condition that is your baseline. They said, well, we'll assume the normal conditions are obvious. The crisis shows excess deaths. They do acknowledge that this is easier said than done. No one is measuring mortality during a war. Surveys are imperfect. Causation isn't always clear. It's not clear whether your baseline should be pre-crisis mortality or the mortality in a neighboring state that wasn't affected by the crisis. There are lots of debates about that. But you quickly see the controversies. One of the first ones that I have found came out of Harvard School of Public Health, 1995. Mary Kay Smith-Thawsey and colleagues tried to estimate the number of child deaths in Baghdad that could be attributed to the economic sanctions imposed after the first Persian Gulf War. They estimated 567,000 excess deaths. This triggered considerable debate that lingered for decades. When the Iraq War started in 2003, similar kind of interest. People were very interested in measuring the toll on civilians. One early estimate said 45,000 civilian deaths. 2006 used a survey, estimated 600,000 civilian deaths. A 2013 study, looking over a longer period of time, said just 450,000 deaths. But one of the things the editors of these journals were quick to point out is the problem of confidence intervals, especially when you're doing extrapolating based from surveys. The confidence intervals are quite wide. They'd said, the estimate of 405,000 was a reasonable estimate, but based on the statistical methods, what they're really saying is that they're 95% confident the range is somewhere between 48,000 and 750,000. A huge confidence interval. 405,000 was just in the middle. Hurricane Katrina, same kind of issue. The official estimates from the National Weather Service are just over 1,800 deaths, most within the first week of the hurricane. The question was, what kind of lingering effects did the hurricane have? One study just did the simple-minded thing of counting obituaries in the New Orleans Times-Picayune, and they saw a 47% increase in obituaries in January through June 2006, so 6 months after the hurricane, suggesting a lingering elevated mortality, which was certainly what the local population was telling researchers. The most recent analysis I have seen by a group of economists looked at mortality in the 8 years after Hurricane Katrina and completely turns this on its head. They said if you look at an 8-year perspective, Hurricane Katrina actually decreased mortality of New Orleans residents, even if you count the 1,800 deaths in the meantime, because what the real impact of Hurricane Katrina was forcing hundreds of thousands of people out of New Orleans, which was a very high mortality region. Many of them settled in lower mortality cities, such that over 8 years, the mortality benefit they got from leaving New Orleans was in excess of the 1,800 deaths caused in the first week after Hurricane Katrina. I have no idea how reliable the analysis is. It was published in a good journal. I haven't seen a rebuttal of it. Another big one, Hurricane Maria. The official death toll was 64 people. Many people here, including Caroline, were skeptical of the government data. The government had refused to release full data. They did a survey, estimated 4,600 excess deaths, 70 times the official toll. Now, they acknowledged there was a very large confidence interval here, 780 to 8,500. This triggered considerable debate, not surprisingly, in lots of different places, not just in the correspondence to the journal, also in GitHub, also in Washington Post. One thing that came out of the debate was that the Puerto Rican government was forced finally to release the data. They contracted with researchers at George Washington University who estimated 2,900 excess deaths, so still far above the official toll, with a much narrower confidence range, down from 2,600 to 3,200. And Caroline, this is still the conventional wisdom?
I think so, yeah, because this is based on registered death.
Yeah. But then, the latest piece in this story is last fall, Nature published what I think is a jaw-dropping estimate of hurricane mortality. Instead of the average of 24 deaths per storm, which is what the US government reports, they looked at 500 hurricanes from 1930 to 2015, saw excess mortality persisting for 15 years after a storm. So they estimate that the average US hurricane causes 7,000 to 11,000 deaths, making hurricanes responsible for about 4% of all deaths on the Atlantic seaboard. Intuitively, that just doesn't seem possible to me. The goal of this article was to show that what we think is possible isn't right. Again, the methods are way beyond my ability to judge, but I have not yet seen any substantial criticism of this finding, even though it was published in a relatively high-profile journal. Now, I'll just go through this stuff on COVID relatively quickly. COVID, of course, brought excess deaths back to the spotlight. Very early on, May 2020, New York City Department of Health reports 24,000 excess deaths, saying that they were basically just using the same methods that had been developed for flu, so they knew how to do this. CDC follows up in October, reporting 300,000 excess deaths. And here they start to tap the flu wisdom about the various problems with all of this. What are the baselines? How do you count? What's going on? What do you do about underreporting? WHO picks it up, and you'll find excess deaths worldwide. Another group here was involved in looking more specifically in Gujarat out of suspicion that the Indian government was underreporting deaths. They came up with a much higher report of excess deaths. As the epidemic goes on, people realize they are now in trouble because the baseline has been completely disrupted. So if you're looking at 2023 deaths, what's the baseline? You can't use 2022, you can't use 2021, you can't use 2020. If you use 1919, you can do that. But what if there have been secular trends and other causes of mortality over those 5 years? Heart disease is dropping, cancer is dropping. There was wondering what direction opioid mortality was going. So no one really knew how reliably you could use a 5-year-old baseline to track mortality all the way through. And so the Centers for Disease Control starts publishing these elaborate notices. Thankfully, all of these have been archived in various places since there's been so much damage to the CDC websites, trying to explain how you actually can keep track of this. This comes back to the forum I'd mentioned at the start from the American Journal of Public Health. Vanderbroek and Brook talk about how wonderful the technique is, but then quickly go through to describe all the caveats about how hard it is to use it reliably. You can still see the advocacy uses. One of the commentaries by Stephen Wolfe uses the size of the excess deaths in the US to indict how pathetic the American response had been. And then Faust comments about the irony. Even though he doesn't think excess deaths really exist, early deaths exist, and so it's a useful concept. And then, as you've probably seen over the summer, the concept continues to be widely used. There was a revision a few weeks ago. Even though the Los Angeles wildfires officially killed 30 people, there was a report coming out of BU School of Public Health saying it was actually over 400. But again, they have the same problems. They don't know what to use as the baseline because all data from 2020 to 2030, or 2020 to 2023 was confounded by COVID. Again, they talk about this question of harvesting. One of the critics says a lot of this is probably just harvesting. People dying from the wildfires would have just died soon anyway. And again, that triggers usual controversies about all of this. And then another big report just a couple weeks ago about heat waves in Europe, 2,300 excess deaths, of which 1,500 were specifically from climate change. And as you probably know, there are a whole series of assumptions built into claims like this. It's hard to know what to make of them. But again, they get published relatively at an intuitive level without a lot of discussion about the very subtle mathematics that are actually behind this. So where do things stand? The concept is still everywhere. It's ubiquitous in the COVID coverage. It still comes up in a lot of environmental health work. Is it valuable because it's so intuitively clear and you can capture the imagination of journalists pretty easily? Is it valuable because of over a century they now have a pretty sophisticated mathematical basis for how to do these analyses? Or do you think it's hopelessly undermined by the uncertainty and confounding that's embedded within the method itself? I'd be very curious to hear your thoughts. Emily Harrison and I are thinking of pursuing this and trying to write up an article. So any kind of input you have would be very actionable from my point of view. So thank you, and I'm happy to take questions in the time that remains.
David, thank you. Wonderful. Always keeps surprising me. Winston Churchill as an early occupational epidemiologist.
I had no idea.
And also, by the way, the history of this concept, as all the big epidemiologists, Wade Hampton Frost, Langmuir, Winslow, Caroline, Bucky. I'm going to ask the question. Caroline.
David, you talked a lot about baselines. You didn't talk as much about when to stop counting, which is a big issue,
Yeah.
especially for hurricanes and things like that, where you have infrastructure damage, and it's the infrastructure damage that kills people in many modern societies. And that's something that I think the methods they weren't designed for that. And so, so that's one question is to ask you in sort of historically how that's gone, that conversation. And then the other thing is that, excess deaths, there's using excess deaths as a way to design insurance, climate-related insurance schemes, where we could have an epidemiological definition that could be used as a trigger for payout in insurance. So there are kind of a lot of very concrete implications of how this works, and with climate change especially, right, you have the baseline is going up for other reasons, and so, you know, if a heat wave lasts 3 days, okay, if it lasts all summer, what does it mean? Can you say something about where the discussion is, or that you've seen the discussion go from policy specifically?
So two things. So the question of how long the event lasts, I think some of this, you know, the technique really comes into epidemiology on the backs of influenza. 1918, these were seen as relatively short waves. You know, like when Boston gets hit in early September, it's mostly cleared out of Boston by the end of September. So influenza is seen in some level as like a month-long event. And so if you're more than a month out, you're not being affected by influenza. They knew that really wasn't true. Flu mortality would be elevated all winter long. Part of the reason that heat gets recognized early on is because heat was clearly outside of what they considered flu season, at least in the northern United States. And so when you see these spikes, if you see a spike in February, oh, that's probably flu. If you see it in March, it might still be flu. If you see it in June, it's not going to be flu. And so there were lots of not well defended assumptions about when one event ends to make it easier to count. But I think you're right. It's really the hurricanes that bring this question of the long tail into effect. As I said, you know, the analysis initially done at the NBER, the National Bureau of Economic Research, if you look at 1 month after Katrina, there's a huge mortality spike, the 1,800 deaths. Apparently, if you look 10 years out, you see lives saved by Hurricane Katrina, which is such a weird concept. Now, that might be unique to Katrina because of the migration, the mass migration out of New Orleans. The Nature article that reports 7,000 to 11,000 deaths per hurricane is looking at a 10-year tail. And so that would pick up all of those things. The question of how long of a tail to count isn't an objective decision. You know, the researchers are making judgments, and the judgment you make has an enormous impact on the analysis. And that's something that people need to be really aware of. And I suspect if you were to look at various insults to populations, most fall somewhere in between that spectrum of flu waves, which are short, and hurricane, which has long effects. Maybe it has to do with whether there's damage not just to the population, but to the infrastructure itself. I suspect it's more complicated than that. What to do about things like famines, wars, sanctions regimes, that'd be complicated as well. In terms of insurance, one of the reasons why Google Ngram Viewer only gets used so far is a lot of the early occurrences of expected deaths, expected mortality, excess deaths, excess mortality, are in the actuary industry. So it turns out the world is full of actuary journals in the late 19th and early 20th centuries. They are incredibly tedious to read, but they have all been scanned by Google. So they totally flood the Google corpus with all the stuff by insurance actuaries and how do you calculate these things. And it's all about this question of when should these premiums pay out. And so like with so much in demography, epidemiology, statistics, a lot of it starts with the insurance industry because they were the ones who had money online. And so they developed some of these techniques. I haven't seen evidence, and I don't know where to look, to what extent were the public health service people in the 19-teens aware of or directly influenced by the prior work that the actuaries had done. I don't think very much. But now for the question you had about, could you use this to trigger payout, like the heat-related thing that Sachin has been working on. It'd be really hard to do. And again, you'd have to figure out what time window do you put around that. Like if someone says, well, in 4 days in Ahmedabad, there was a mortality spike, so that triggers the insurance. You could see an insurance executive say, well, no, we need a longer time frame to understand what the mortality really was. Let's wait until we have 6 months data, which would stall the payouts, and then allow the signal to get washed out by everything else that happens in the intervening 6 months. One of the things that has come up when they've been trying to figure out with heat waves how much of the deaths are harvesting is the same issue. What time window do you look over? And so there's some people who say, well, if you're going to address harvesting, you need to look at the year after the heat wave. But the year after the heat wave includes a seasonal flu pandemic of variable size, which totally bombs your data series because you have no idea from 1 year to people have ideas. It's hard to know from one year to the next how big that flu spike is. And so this question of the time windows, I don't think can be resolved analytically. It's always going to involve political compromises and a lot of pushback because money's involved.
Thank you. Alec Walker.
The
And Mark.
the analysis here parallels very closely an analytic epidemiologic technique called a self-controlled case series, in which all the exact same questions arise. How long do you define an effect period? What model do you have of effect? What model do you have of lag times? And as I understand that area, if you get beyond the very simple notion of while you're exposed you have the effect, then you explode into a universe of hypothesis, which makes it almost impossible really to know what's going on.
Yeah, that sounds right. And what I'd be interested to know is, when was that body of literature being developed in relation to this? If you have any references to something, I'd be very grateful. I went back and forth with Mary Kay a lot about causal inference theory. Many people in this department have played a huge role in the development of that literature, especially since the 1980s, 1990s. My first response was, well, but these arguments are taking place at a level of extreme mathematical sophistication, and that's not what I see in the excess deaths literature. And then Mary Kay responded with a whole set of articles that were much more qualitative level engagement with causal inference theory. And so there's quite a lot else going on in epi theory during this time that's relevant that I'm trying to pin down. So if you have anything to send, I'd be just as a starting point.
Probably know better, but I would guess in the popular discussion among analytic types, the last 30 years maybe.
Okay.
Yes, please.
Hi. So in the beginning of your presentation, you showed the charts based on the frequency, you search SSL, dev, or Google Books.
80s, 80s, 90s.
Yeah, and then at least essentially you ignore other language, SSL, dev, other language.
You could spend hours sort of just using different kinds of searches, finding different patterns. There are I probably had a list of 10 or 15 different related terms. One that comes up is excess deaths versus excess of deaths. I don't think there's any difference in meaning between those two phrases, but they're different collections of English words, and so you can graph them separately. So you can get a graph of excess deaths, and you can get a graph of excess of deaths. And then you just bang your head against the wall trying to decide, is that meaningful or not? And if Google Books were a totally ironclad, robust, accurate corpus, and not a somewhat random sample of everything that's been published, then it would be worth trying to figure that out, and then you could probably extract meaningful time series. But the underlying data set doesn't justify the hard work that would be required to answer that question.
Still, this thing, this dip, the bump in the probably early 80s or so, seems to be all the time. You see it in all the things. Any idea what that is? No?
The answer is always AIDS, but I'm not sure if that's actually what it is. Yeah.
This is just a question about the terminology. So you were saying excess deaths attributable to some event, but in my head, attributable deaths are different than excess deaths.
Yep.
They're a portion of excess deaths. And I'm curious how you're thinking about deaths that can be attributed to a necessary cause, and also if you're thinking about excess deaths as both the indirect and direct deaths associated with a given event.
Yep. All those are excellent questions. And certainly in the period into the 60s, people aren't wondering about that. They're mostly operating at the intuitive level. If there's a spike in the winter, it must be from flu. And they don't get much past that. And I don't know why that is. But it would take a lot of work to try to figure out exactly what's going on. Or this question, does premature mortality mean something different from excess mortality? I think it does. But were the people using those words, using them consistently and reliably? That goes back to your question. I think the answer to that is no.
Mark, you had a question. Mark Lipsitz.
Yeah, so thanks. That was really interesting on lots of levels. One thought is you started with an example where Farr, I think it was trying to define the ideal or the
Natural, yeah.
natural rate. And it seems like the use of historical comparisons is an improvement in the sense that the natural rate, for a given lifespan, the natural death rate will depend on the birth rate. Because the population pyramid will be younger if it's a fast-growing population. So the notion of a natural rate is kind of silly, even if you believe there's a natural lifespan.
And one of the things that is interesting in his writing, he quickly gets into these highly romanticized descriptions of the English countryside. Because and the baseline of the high mortality was London and Liverpool, and anyone who's read Engels or anyone else knows what a hellhole those cities were in the 1850s. But then he has these accounts of these blissful English rural pastoral towns with these much lower mortality rates and all these happy farmers and their cows. But it's like, he clearly doesn't, and that's not what life was like in rural England. And so it's hard to know what to make of all of that. But the question of the age distribution, they realized that's an issue probably by the early 20s. Again, when Langmuir, when Frost and Sinstrick are trying to make comparisons across regions, they realized that different regions of the country have very different age distributions. And if you're not careful with that, then you're going to have a bad analysis. And then they quickly realized they don't have good data on age-specific flu mortality rates. Langmuir probably does by the 50s, but in the 20s, they just don't have the data infrastructure. So sometimes they were aware of issues that they ought to have been paying attention to, but knew that they couldn't.
Final questions?
Yeah, quick comment and an additional question. The comment is, it seems to me all the complexity, this excess death concept is very important and valuable. It acknowledges that some data that whether it's a natural disaster or a man-made disaster has causes mortality that isn't always captured in what's written in the death certificate, and we need ways to try to capture that. So I think, we shouldn't, all of us should remember it's very useful. The second is, what about the obverse of it? Something, access death is some bad thing happened, and it had even bad, additional bad, what else thing good happened? Someone came up with a good vaccine or a intervention, and it didn't just reduce this, there was a vaccine for, respiratory thing. And then the deaths went down, not just for respiratory, but also for other things in that same period. Does anybody talk about that? Shortage of deaths, excess health.
Preventive death.
Well, I don't even know what the term would be.
So the answer must be yes. And I'm trying to think of an early example when that was recognized, that there was a collateral benefit to a population-level health intervention.
Omeprazole stem ulcers. You can see big drops when the first antacids came out. Over the course of less than a year.
Yep. And so there are going to be a lot of examples. I haven't seen discussions of that. Again, that might just be sample bias and where I've been looking. But the question of when does someone first recognize that an intervention targeting outcome A has a wonderful impact on unrelated outcome B? That'd be a really interesting question to try to get to the bottom of. And I said, I'm actively working on this, so if anyone has more leads or comments and suggestions, I'd obviously be happy to talk more and hear any of them.